Hello friends, today I'll be discussing this congenital CMV infection and pregnancy. I'll be discussing the scientific impact paper 56. The CMV infection, also known as human herpes virus 5, it is the most common viral cause of congenital infection, accounting for around 0.2 to 2.2% of all live births. It is a leading non-genetic cause of sensory neural hearing loss and major cause of neurological disability in children. It has been seen that only 10 to 15% of the neonates who are infected with congenital CMV are symptomatic at birth. So this congenital CMV infection, it can be caused due to either primary infection in the mother or recurrent or secondary infection in the mother. So this primary infection is that the mother is infected for the first time in the pregnancy, and recurrent or secondary infection is when she was previously infected, then the virus was in her body in the dormant stage, and later due to any immunocompromised stage like pregnancy, this virus gets activated and results in recurrent CMV infection. So it has been seen that risk of transmission is much more in primary infection as compared to recurrent infection. With 30 to 40% risk is seen in primary infection. Of these, 13% are symptomatic, and in recurrent infection, the risk is around 1 to 2%. Since this recurrent CMV infection is much more common, so it has been seen that although the primary infection has more transmission risk, but it has been seen that around 2/3 of the infants with congenital CMV infection are born to the mother who have pre-existing CMV infection. This is because of the higher prevalence of recurrent CMV as compared to primary CMV. So the risk of vertical transmission also varies with gestational period. It increases as the gestation advances. It has been seen that in first trimester, the risk of transmission is around 30%, whereas in third trimester, it increases to around 47%. So although in early pregnancy, the risk of transmission is much lower, but since the organogenesis and all takes place during the early pregnancy, so the infection is much more severe. Symptoms in mother. Majority of the females are asymptomatic. Only minority will develop symptoms, and those symptoms are also very non-specific. They mimic symptoms of infectious mononucleosis. The symptoms like fever, malaise, myalgia, cervical lymphadenopathy. Less commonly, it can result in hepatitis and pneumonia, and very few of them suffer from long-term sequelae. As already discussed, the CMV infection can remain dormant lifelong. And the most common site of dormancy in our body is salivary glands. Coming over to the symptoms in the neonate. So when the neonate is born, the most common symptoms are jaundice, petechial rash, hepatosplenomegaly, microcephaly, and generally these infants are born small for gestational age. And only, as I already discussed, only 10 to 15% or 13% are only symptomatic. Remaining 87% are asymptomatic. However, 6 to 23% of these asymptomatic neonates have chances to develop later in their life some degree of hearing loss. So how do we screen for these congenital CMV infection? Usually, routine screening is not recommended. There are only two indications for screening. First is if the women develop some symptoms like influenza or symptoms like glandular fever, as already discussed, and we have already ruled out Epstein-Barr virus. Or the female develops symptoms of hepatitis, and we have ruled out other types of hepatitis. Or during routine ultrasound scan, we find certain abnormalities which are specific for CMV. Some of these are ventriculomegaly, microcephaly, calcifications, intraventricular synechiae, intracranial hemorrhage, periventricular cyst, cerebellar hypoplasia, cortical abnormalities, echogenic bowel, small for gestational age, pericardial effusion, ascites, and fetal hydrops. So, this was about screening. Now, how do we diagnose? So, maternal diagnosis is primarily by IgG avidity testing. High avidity is if it is greater than 60%, that is called as high avidity index. Next, it indicates it's past infection, that is more than 3 months, or secondary infection. And low avidity index, which is less than 30%, indicates recent primary infection or within past 3 months. So, CMV, coming over to how to diagnose this fetal CMV infection. So, this is about intrauterine diagnosis. It's usually diagnosed by detection of the virus or the genome in the amniotic fluid, and the test which is used is real-time PCR, and it is usually done after 20 weeks of gestation, because in the amniotic fluid we are usually detecting the virus which is secreted in the fetal urine. So, the kidneys are well developed only after 20 weeks. So, there is point of doing this test only after 20 weeks of the gestation, or it is done at 6 to 8 weeks after the infection, because this much time is required for the manifestations, ultrasound manifestations, to occur. So, how do we manage in the mother? We do not, all the antiviral drugs which are used for CMV, they are not safe in pregnancy. Acyclovir and valcyclovir, although they are not licensed for use and have limited activity against CMV, but they can be used and they are safe in pregnancy. We do not have any vaccine for prevention of CMV. The only thing which helps are the simple hygiene-based measures like repeated hand washing, avoiding contact with the infected person's secretions like saliva, urine, or avoiding sharing utensils, food or drinks, anything. So, these all help in prevention. Also, once the fetal infection is confirmed, intrauterine infection is confirmed, then we have to do fetal monitoring. It is done by serial ultrasound examination, which should be performed every 2 to 3 weeks until delivery. Cerebral, second investigation is cerebral MRI, should be first done at 28 to 32 weeks, and if required we can repeat it 3 to 4 weeks later. In case there is intermediate prognosis, I'll discuss what this intermediate prognosis mean. Then we can go for fetal blood sampling to check the platelet count. So, coming over to the management. So, management is based on whether the fetus is the infected fetus is asymptomatic or symptomatic. Asymptomatic means there is no ultrasound abnormalities, there is the cerebral MRI is normal, the other biological parameters like platelet count, everything is normal. So, in these fetus the prognosis is good, and we can go for expectant management, that is continuation of pregnancy, and we'll just do monitoring till delivery. We'll do ultrasound, we'll do MRI, and if required we can do blood sampling. If symptomatic, it could be mild or moderately or severely symptomatic. In both these cases, we'll give the option to the female to go for either expectant management or termination of pregnancy. It's up to her to decide. And if she goes for expectant management, then we'll follow her till delivery in the same way like we were following up the asymptomatic cases. And on delivery, we'll we'll do the placental examination to see for any changes, calcification and all. And we'll do postnatal examination of the baby. We'll look for we'll assess olfactory, neurological, ophthalmological, any abnormalities are there, we'll assess for that. And if the women opts for termination of pregnancy, then we can then again we'll do the placental or post mortem examination to look for any changes of CMV. So how will we diagnose once the baby is born? and the women has opted for expectant management, then first we have to confirm the infection in the newborn. This can be done by urine or oral swab, which are subjected to CMV PCR. Ideally, it should be done within 3 weeks of birth. And how to manage? For treatment, if the baby is symptomatic, as already discussed, only 10 to 15% will be symptomatic, then we can go for postnatal valganciclovir or ganciclovir. These drugs are not safe during pregnancy, and these drugs should ideally be given within 4 weeks of life. It has been seen that the treatment of this CMV infection, it reduces or prevents the progression of sensory neural hearing loss, and also improves the long-term neurodevelopmental outcomes in these infants. So this was all. Thank you. I hope you enjoyed.